afternoon, good evening, and welcome everyone to this week's Global Cafe. So as Ashley said, my name is Katrina Bazanis. I'm a Director of Policy and Advocacy at the IFA, and pleased to be with you today for a very interesting topic. So older people face a number of challenges and inequities, particularly when it comes to ensuring their ability to live in good health and well-being. And so today's Global Cafe is really an opportunity to shed light on the often neglected ethical dimensions of health equity in older age, as well as the ethical implications of some of the disparities experienced by older people, particularly when these disparities trace back to social conditions that have affected them throughout their lives. So improving the lives of older people involves protecting their rights, but also improving the ability to live in good health throughout the life course. Given global population aging, but also the injustices that older people have long faced, there's a need to examine inequities that exist, kind of some of these ethical challenges of healthy aging, and think about some strategies to tackle these challenges. So with us today to discuss some of these very complex topics is Professor Sridhar Venkatapuram. So Professor Venkatapuram is an interdisciplinary academic practitioner in global health ethics and justice. He is an associate professor at King's College London and has worked with a number of great organizations, including WHO, NHS, Wellcome Trust, and many others. He lectures and publishes widely on global health ethics, as well as global and health justice philosophy and health equity. So Professor Venkatapuram, we're very happy to have you with us today.
Oh, good morning, Katrina, and good morning to all of you. Thank you so much for including me in your cafe series. It's an absolute privilege.
Yeah, thanks so much for being here. So to kick things off, we always kind of go back to the beginning on the Global Cafe to learn a little bit about yourself and your story. But I'm sort of interested in you're a philosopher by training, if we can call you that. So how did you first begin to get into the study of philosophy, but also start to bring in this component of health and human rights and health?
Yeah. So it's a long story. I won't bore you with the, very detailed, but I'll tell you sort of the general sort of events that I would explain it. Is that when I was in university, I was very interested in development because I was born in India and raised there, and then I grew up in America, and I was interested in sort of how I could contribute to development of countries who sort of were still in poverty, et cetera. And at the same time, I was particularly affected by some events that had happened in India that I felt were required some sort of non-medical attention, which was that one was, some of you may remember, something called the Union Carbide disaster, which was that a company had a chemical leak and subsequently, thousands of people died and suffered and had great complications. And there was, in a way, no response or justice for those people. A lot of people were essentially, sort of died without sort of any kind of acknowledgement or fairness. And so this, to me, had a particular international implication because this was an international company. And because it was such a large international company, it didn't seem to have to be sort of regulated or could have out of reach of sort of the Indian government, even if the Indian government wanted to do something. So that was something that I felt had something to do with international relations and the fairness of the international system. Around the same time, when I was in university, there was this growing fear and awareness of something called the AIDS epidemic. And what was happening was that even in rich countries, governments were reacting to it either by ignoring it, by saying that it's not something that exists in our country, those kinds of people that are affected don't exist in our country, or they were implementing public health policies that were very draconian, sort of mass testing, forced quarantine, etc. And so I started with an internship at an organization called Human Rights Watch, which was very much an organization that was, looking at the relationship between government and citizens and sort of what was sort of going wrong in various kind of places. they had never looked at a health issue directly per se. So I was the first one where they knew that lots of really bad things were happening. And so we sort of began looking at health, particularly HIV/AIDS, from a human rights law perspective, saying what are the rights that citizens have and what sort of rights are being violated by a government. But the interesting and the real kind of moment was that, the then director of Human Rights Watch and I were chatting, and he says, "So what do you do?" And I said, "Oh, I work on HIV and human rights." And he said, "Well," and he looked very puzzled, and he said, "Well, we don't really think that there's a human right to health." And I said, "Well, what do you mean? Like, there's a problem." And then he said, "Oh, I'll send you this essay that, you can read." And so there's this very famous essay by a philosopher called Isaiah Berlin called Two Concepts of Liberty. And so where he lays out that the idea is that freedom can be envisioned as freedom to be left alone, and freedom in the sense of being able to do various things. And he argued that governments should be in the business, democratic government should be in the business of kind of leaving people alone in order to help them, let them decide what they want to do for a variety of reasons. And that's why many Western countries during the Cold War really only focused on civil and political rights, because they believed that it was about leaving citizens alone to live their lives. So if you're a health advocate, leaving your, government leaving you alone isn't necessarily the only thing that matters. And so that's where I got into philosophy, which is how would we make a philosophical argument for a right to health that overcomes this kind of notion that there's positive and there's negative, and we only care about the negative. So that's how I became a philosopher. I sort of then started to look at philosophy, this idea of freedom, positive and negative liberty, and then also health. And it took, a lot of time, many years, but I ended up, I think after 10 or 15 years of starting all of this, ended up doing a PhD at Cambridge, and making that argument called, about a philosophical argument for a right to health. And that ended up being my PhD, and the book called Health Justice is about that kind of argument. I hope that wasn't too long of an answer. I'm hoping that by saying all of that, many of the people in the audience will pick up on something and sort of carry us on forward.
Yeah, no, that's great. I think it's really helpful to understand how these disciplines kind of came together, because I don't know that it's an obvious thing maybe for people either working in, strictly human rights or working strictly in public health. So I kind of I'm interested in the bridging of the two together. And I'm also conscious that something like philosophy, a discipline like philosophy is very different, I think, in many ways, just in terms of the ways of working, than a discipline like public health. And I'm wondering if there was any kind of challenges or any interesting kind of insights that you learned from bringing these two disciplines together in your work, because I think on the one hand, public health can be, very scientific, very black and white in a certain sense, versus philosophy, which is kind of the antithesis of that.
Yeah. So, in exactly what you said, this is why it took a lot of time and many degrees to be able to do what I'm doing. So I'm actually trained in international relations, was my undergraduate. Then I did a master's in public health. And then I did a master's in sociology and globalization, and then a PhD in political philosophy. And it's precisely what you said, is that, these aren't necessarily obvious connections, but more importantly, if I did only one discipline, it's not clear that the other one would listen to what I had to say or to be able to do it. So I wanted to be really sure that I could engage with all the different kinds of disciplines and talk across different disciplines and professions to be able to do that. So that is, my form of interdisciplinarity, is actually learning all these different disciplines. What actually comes to the forefront is that there's actually a necessary relationship between philosophy and public health. So, for example, just to give you a sort of brief example, in the science of epidemiology, some people might think, oh, epidemiology is very scientific, it's very objective, but there's a lot of philosophy in it when you are trying to show that there's a pattern, and in this pattern there's some sort of relationship about causation and what are the standards that you use to establish causation, and then you want to argue that the way that the intervention is not necessarily going backwards in the causation, but a new intervention that addresses the impact. These are not sort of necessarily black and white things. These are all very much about understanding philosophical concepts such as causation, and to be able to make conclusions and explanations, etc. On the other side, I think public health people and health policy people often want to do something, and they often use philosophical and ethical language to justify or motivate their policies. So someone might say, oh, I believe that every person matters, and therefore we are going to implement this policy for X, Y, and Z. And so, that's one thing. Or somebody might say, oh, I think everyone has a right to something, and then therefore they want to implement certain kinds of policies. Or some people are very motivated by this idea of, let's say, gender equality and women's rights. And so then they spend their entire careers researching health issues of girls and women. So there's lots of ethics and philosophy in public health as well. So I think that there's sorry, I should say the balance of that is that the philosophers sometimes can be seen as remote ivory tower individuals who work only with ideas. But there's a group of us, and it's growing, and many of us who care about the real world. Some of us get into political philosophy in particular because we care about issues in the real world. And what we're interested in is bringing greater clarity and understanding and coherence to some sort of policy response. And so we are, we can't do this without actually knowing what the issues are and the details and the science and the economics of it. So we engage with the disciplines in order to make our arguments more well-founded, but also appropriate and relevant and effective as well. So I think there's lots to be said. I hope that I am making philosophy more accessible to people, and to make it sort of understood that philosophers, there's many of us who actually care about empirical sciences and all that kinds of stuff.
Mm-hmm.
Thanks.
Yeah, no, thank you. I think it's a great, it's great to see that connection being made between what's happening, because I do think you're right. There is this maybe perception that people in philosophy are, it's very theoretical, but I think that's, as you're pointing out, that's not necessarily true. And I think it's great to have those connection points that, people can anchor onto to really understand how it can support kind of health and politics and all of these different things. So I want to dive into the idea of health equity, and particularly, connect that to aging. So how does health equity impact how we age, longevity, the health of older people? And why is it important to think about these things when we're talking about, aging populations and healthy aging?
Yeah, this is fantastic. I could spend the entire day talking about this. So I'm going to try to bring this to a very sort of thumbnail sketch. I think the concept of health equity, just those two words, different people come at it from different ideas and different assumptions and understandings. So the way that I use health equity is in the following way, which is that a lot of people who care very much about fairness and justice often think about equality as our goal towards something. So they think, oh, if something is fair, then that means that it's equal, etc. In health, we can't and we shouldn't aim for equality across people when it comes to health for a variety of different reasons. So for example, men and women have on average different life expectancies. Women live longer than men. So we don't want equality in life expectancies. And so equity is a term that, I and others have been using in order to say that, there are some differences that are something that we can't do about anything about, and shouldn't do anything about. We're not trying to aim for equality. So this idea of equity is trying to reconcile that sort of notion of differences that are, natural, perhaps, that we should sort of accept and not deal with. Now, the work that's happened over the last 10 to 20 years is to show that equity is not just we don't care about it in just one dimension, we care about it in multiple dimensions. What I mean by that is that when we're talking about healthcare, for example, two people who come with the same kind of health issue, we want to say should be treated equally. But if one person broke their leg skiing on vacation versus another person broke their leg because a police car ran over it, then we have a society, as a society, have different moral sort of approaches and views about two different causes. And we think that we should be doing something for one person while another person should have more responsibility for that in the second case of the skiing accident, for example. So we're interested in the causes and the morality of the causes. We're also interested in the kind of distribution patterns in a population. That are they random, or are they patterned in a particular way because of the way that we organize things? We also might be interested in levels. So what I mean by that is that if you only look at one country and say, well, this is the level of health in that country, that is what it is. But if you look at a bunch of countries and you find that there's many different levels and some countries are much healthier than others, then we're like, oh, wait, so this one country, this could be much higher than it is. And so that seems like we should be caring about levels as well. We care about the experiences that people have in healthcare, but also in society, that two people who walk into the same healthcare setting might have vastly different experiences because, they're a man or a woman or white or black or brown, or there is sort of different kinds of religions. And so we care about the sort of the experiences, and we care about the consequences, and we care about the non-health consequences. So for example, two people who have a particular health issue, one might severely suffer economically because they have that, while another person doesn't. So all this is to say is, in my perspective, health equity is multidimensional. It's sort of all these different dimensions matter to us about fairness when it comes to that. So I apologize for taking so long to answer your question. The second part of it, what does this have to do with older people? So what we've done, unfortunately, over the last few decades, particularly in framing these issues, is that we focused a lot on fairness in healthcare. And I think that's an absolutely important issue, and how older people should have access to healthcare. And a lot of arguments have been made that somehow older people have had their life chances and we should focus healthcare on younger people because it's more fair that way. I think that that's a very narrow argument for very specific situations. But beyond healthcare, what we care about is, just like I said, in all those dimensions, older people have a very particular experience in all those dimensions, and we want to pay attention to all of those as well. And more generally, the idea is that there's lots of unique things that are happening in older ages that we need to acknowledge and think about in terms of fairness as well. So a couple of concerns that I particularly have is that when we look at a population and see health differences across the population, we see a pattern of inequality. And we think, gosh, this is a real problem that some groups are doing so poorly and some groups are well. But if we look at older people in particular as a group, we find those inequalities are much wider. So there's more health inequalities within older people than there might be across the population. But we don't look at that. We just think of older people as one group. And I think that this is a real problem. And some people don't even get to old age. So that's actually a really pressing problem, that there was something unfair or unjust about some people not even getting a chance to become older people. So there's, if you're interested, we can talk much more specifically about that. But I just wanted to give you a flavor of this idea of how I think about health equity as being multidimensional, and how, when it comes to older people, we have this, particular prism at which we looked at health equity, but also there's some new and unique parts of being older that require us to think about health equity in different ways.
Mm-hmm. No, thank you for that answer. And I think you're right. I think we always talk about this idea that, older people are not a homogeneous, population. There's quite a mixture within older people. And so that is kind of a point to look at of, why do some people have such, great health outcomes, able to have such kind of longevity and things like that, versus others that, as you mentioned, don't even become older people, don't even get to that stage. So I do want to go to a question in the chat from Shmuel, who is one of our regular contributors at the Global Cafe. And so he's asking, what is the role of governments and different authorities in ensuring health equity for different age groups, including older adults, but also those from, low income populations, thinking about socioeconomic status as well?
Yeah, I think the question is first about what does the government responsibility towards health equity regarding poor and low income populations, including older people in that sort of socioeconomic group. So I think that, this, really comes to the heart of, my philosophical work, and probably the reason that I'm here, which is this argument that, every person has a moral claim to be able to live a long and healthy and flourishing life. That is sort of the starting point that that I come with. But a lot of philosophers, and every one of you, I bet, believes that every human being who is born has equal moral worth, and they should have equal opportunity to live a long and healthy life in the way that they want to live. So when it comes to, well, what is a government supposed to do with that? I think the government isn't an alien entity. A government is supposed to be a reflection of us as a society, and us as what we want our society to be like. So I remember one philosopher, Joe Wolf, said this once very clearly. He said, the government has no money. The government has our money. And so it's a really kind of, important realization that this is, the government's supposed to be working for us and reflect our values. And we are seeing sort of great debates because people essentially want to control it in a particular way that they want it to go. And this is one of the reasons that we're in such polarized situations. Anyway, to going back to that sort of earlier thing, I think, for history, since history began, we have known that there is a relationship between poor health and poverty. That is, that if you are poor, then may not have the resources to be able to protect your body and yourself, and have the ability to access nutrition, have the ability to protect yourself from different kinds of threats, etc. So a lot of people for a long time have assumed that material poverty is a cause of ill health. I'm going to skip over all these academic debates about culture of poverty or genetics and all this other kind of stuff. I'm just going to focus on the material stuff. So, we've all decent societies ensure that nobody dies from poverty. That, that's the idea, is that we sort of want to be able to ensure that people have the basics when it comes to that. But beyond that, over the last 3 decades, what we have learned is that it's not just material poverty that keeps poor people unhealthy or the middle classes unhealthy, that it's beyond that, which is that the social conditions and how we relate to each other has significant impact on our health and our well-being. So these concepts such as weathering, I'm sure many of you are familiar with it, which is that if you experience racism for decades on end, your body physiology is actually living in such a state of hyper tension and anxiety and paranoia that the biology is actually aging very rapidly, and so your body's aging rapidly. So someone who's poor and experiencing racism is going to sort of experience that weathering. But it's not just racism. Being poor is also very stressful, and that can actually cause different kinds of stuff. So for me, the role of government really is about addressing these conditions and these relationships that are actually constraining people to live free and flourishing lives. That's the justice part of what we do, is saying, you know, a good society, a just society removes those obstacles that constrain the abilities of some people more than others in terms of being able to live good, healthy lives.
Mm-hmm. Yeah, thank you for that response. I think, yeah, I mean, obviously there's lots of literature around, you know, just trauma as well as racism, ageism, and how all of that impacts kind of health as well. So I appreciate you bringing that in there as well. So I want to ask about some of the ethical considerations around healthy aging, and hopefully, you know, help to also hear from the audience as well, in terms of when we think about healthy aging, and you know, that last question is all part of it, because all of, you know, socioeconomic status and all of those things also go into healthy aging, not just in older people, but throughout the entire life course. So, you know, what are some of the most pressing challenges that you see in terms of ethics and healthy aging? And I'm hoping that some others, you know, from their work, and people from the audience can also chime in to also generate a little bit of a discussion on what people see as some of the biggest challenges that we need to address when it comes to ethics and healthy aging.
Yeah. So, I mean, this is a great question, and I really want to, you know, sort of, again, support what Katrina just said, is that all of you are the people that know what the pressing ethical dilemmas are, that sort of are difficult problems, but also you feel are injustices. I don't want to be the philosopher that sits in their office and comes up with problems that, you know, I think are really important. I might have some ideas, but really, you know, this is an opportunity for you to tell me, but also to raise a conversation about, these are the ethical issues that we should be talking about and we should be raising regarding older people. So, but given that you asked the question, I would say that a couple of things. One is that I really, really would like to expand the conversation about equity among older people beyond access to healthcare. I think we need to start talking about opportunities to live well during older ages, and what are the, you know, kind of constraints that different people and different groups in society and across societies face. And it's a matter of, you know, justice, that we ensure that all people have that opportunity to live that kind of stuff. Second, I think ageism is not only a, you know, a concrete problem, it's a deeply ethical problem. You know, it's really profoundly unfair that you take an arbitrary number and you say, okay, you will sort of be access to this or don't have access to this because of these arbitrary numbers. And so we need to have a better way of thinking about what are people capable of and how can we assess that so that they can do what they want to do. I think, you know, really serious problems such as physical, mental, sexual, financial abuse of older people is just simply not given the attention that it deserves, partly because, you know, the people that are most vulnerable do not have voice to advocate for themselves. And so that's why we don't see, you know, the advocacy or the raising of the issues. This is one of the paradoxes of doing work around justice and equities, that the people that need assistance and require a voice are the least likely to have it. So we need to really think about how do we, you know, give recognition. And I could list a long list, but I'm going to end, you know, sort of with the third thing that I really am troubled by, which is that in conflicts such as the one that's happening now in Gaza and Israel, and in other humanitarian conflicts, older people are ignored. They're often left behind from difficult situations because they're older and they don't have the ability to walk hundreds of miles or to do various kinds of things. And then even in humanitarian camps, the way that we provide assistance and the donors and funders, they give it for who they think are the most needy, which they identify as women and children. And I find this really troubling that somehow there's a preconceived notion of who are the neediest in these humanitarian camps, and that older people who might have various kinds of disabilities, but also different kinds of chronic diseases, they don't have help and medication that they need in order to do that, or different kinds of support mechanisms. So I think, even in where we say we're doing crisis and emergency response, to ignore older people is, I think, really unfair. So like I said, I think there's lots and lots. I could list a lot, but I would say that those would be the three at the top of my list of sort of raising greater attention to and awareness about.
Yeah, thank you. So I think those are some great points, I think often ignored, very often ignored. So I do want to go to David Richardson, who's posed a question in the chat. David, do you want to unmute and pose your question?
Sure. These are interesting thoughts, and they're I suppose by definition being philosophical. They're deeper than, I suppose, the way we normally treat social and political issues. And I'm wondering, where in the broad system of healthcare do you see realistically this sort of philosophical dialogue taking place? Obviously, political level, your degree is in political philosophy, and that's one level at which you would hope that this sort of dialogue would inform public policy. Does it take place among health professionals who have their own sets of obligations and so on as part of the ethic of their profession? Does it take place in the public fora, which notoriously in today's world is polarized and belligerent and not kind of philosophically capable, perhaps, of having a meaningful dialogue on these sorts of questions? So I'm just wanting your opinion as to where you see this kind of dialogue taking place so that it does inform public policy.
Yeah, that's such an excellent question. It's something that I deal with every day, because it's a question for me about where do I want to engage in the world. And so I think one extreme position is, oh, this should all happen in the philosopher's seminar, right? This is the easy place because, it's people that are recognizing certain parameters of discussion. They understand how we're going to talk about it. They know, what we're trying to aim. And the primary objective is clarity and coherence rather than sort of real world impact or something like that. And I think that there is a room for that. And there are different kinds of reasons and opportunities to do something like that, where, we are focused very much on clarity and understanding, and to be able to make arguments that may not be politically feasible or sort of, in the realm of possibility, but we should just still think through them to see whether what's going on. At the same time, I think that, there is something to be said for engaging with the people that we are talking about so that we are relevant. The reasoning is relevant as well. So there has to be a place in which people who are consider themselves philosophers and thinking about health equity from a academic and philosophical point, engage with people who want to articulate their experience, but their own ideas and their priorities, etc. So there has to be that kind of bridge as well. And third, I think when it comes to policymakers, what I've learned over the last, sort of 2 decades of trying to do health advocacy is that most politicians and policymakers go on a day-to-day basis and they need a solution on any given day. They're not interested in learning per se. They're not interested in a seminar for a day or something like that. So it's too late really to try to sort of on any given day, what they want is tell me a policy that is, health equity like. And so give me that, and that will get me something new on the table that I can put in the discussions. So perhaps there is a role, like, some people have their secret policy in their pocket. They're waiting to sort of show some politician that they want to be able to run with. I think that you have to get to them earlier, is that you have to develop networks of politicians who are interested in this, that you build relationships and they appreciate that, I'm not an ivory tower philosopher, or you're not just a kind of armchair philosopher, but this is something that sort of needs to happen over a period of time. And so in different countries, there is different kinds of mechanisms for doing something like that. In the UK, for example, we have something called the All Parliamentary Party Group. They're called APPGs, which are sort of almost like a study groups or event groups that sit on the side, that sort of over time, they sort of raise and expose different politicians to this kind of stuff. I think, sorry, my camera has just gone off. Okay, great. Sorry. It's only the important points that my camera decides that it's going to show its sort of importance. I think that there's lots of different kinds of ways. I think, I also want and I'm trying to get this into education early in all the different kinds of healthcare, but also health economics is also really important. It's not just the, health economists are deciding what the resources are for the healthcare and health policy people. So those are all important stuff. So these are, I'm just thinking out loud of how I'm trying to do it. But your question about public discussion being polarized is a really important one. And it's an important point. From a philosophical point of view, it is wrong, I think, for a few experts to come up with a value-based policy that determines who's going to live and who's going to die, who's going to suffer and stuff, without a legitimate foundation for that kind of ability. You have to be able to engage with people and have public deliberations to make sure that you are not imposing kind of selective values on a population that doesn't agree with those values. This is as much true and even more true at the global level, where, some policy regarding older people is considered to be economically really viable and sort of epidemiologically makes sense, but the values don't mesh with the population that they are going to be applied to. So for example, in the case of humanitarian emergencies, some populations value older people more than they do younger people, because they think of older people as wise repository of history and culture, etc. But funding and global funders see young people as being the people that they should actually fund and save. And so you see this real conflict. So public deliberation and involvement, I think, is got to be part of this process. And I agree with you that there is many issues on making this public deliberation more fair and easy. And I see today in this cafe as one part of that kind of public discussion is sort of, getting your thoughts and getting your questions and me sort of sharing what I know as well, and then also learning from you. And this is very much part of the public deliberation process.
Mm-hmm. Yeah, thank you very much for that response. And thank you so much for that question, David, because I think it is important. And I think for some of maybe the more realists in the room, it's important to make that connection in terms of practically, why should we be talking about this? Why should we be, philosophizing on some of these things? There's a question from Amy, which I think builds on what you've just been talking about, Sridhar, which is, could you share some good examples that you've seen of how government or health professionals are addressing health equity?
Sure. So I think that I don't, your question is, and as a philosopher, I'm going to complicate your question, which is that, did the government proactively aim to improve health equity when they implemented the policy, or is it that the policy ended up improving health equity and then therefore it's a good policy? So I'm going to go with the former, which is, are there examples of countries that proactively said we're going to improve health equity, however they defined it, and then sort of implemented and it got better? And I'm sort of thinking, of a couple of examples. So in Brazil, the rolling out of a health insurance scheme to all its people, particularly the poorest, is an example in which a government said, we want to address access to healthcare of the poorest people, and therefore we're going to roll out this sort of insurance program that allows people to access this kind of services. There is also, I think, some health economists and other people point to how when the East Asian countries such as Singapore, Taiwan, South Korea, etc., had a burst of growth during the 1970s, 80s, and 90s. And you see a remarkable difference in the health profiles of these countries. That's because the countries, when they implemented these economic growth programs, South Korea, for example, ensured that they invested in education and healthcare. And so that ended up so that their population is very educated and very literate, while other countries really just focused on improving GDP. And so they might be rich, but then they have an economic shock and then they're poor or they suffer. So those would be sort of some examples that I would say about health equity. That is where countries, governments proactively from the beginning aim to say, we are going to improve equity when it comes to health outcomes. And we are implementing policies that we hope will, sort of produce those outcomes.
Mm-hmm. Yeah, thank you for sharing those. I'm going to go to another question from Eileen, I believe, from Ireland. Eileen, did you want to pose your comment and question?
Yeah, thank you very much, Katrina Sridhar. Thank you very much. I must say, I didn't expect to be back in university talking about philosophy. And I said it's an interesting break, but I love the connection. Can I just ask you, just on something that you said, have you any thoughts on, you're placing the health on the social agenda but in national governments where they have budgetary policies where they tend to ration out health for, towards care, and moving it towards individuals and empowering individuals and older persons. What sort of challenges and tensions do you see there? Because that's what we're facing every day in our lived experience.
Yeah, absolutely. So I think that, one of the most interesting things that's happened over the last few years, particularly over the last 3 to 4 years, is this concept of health equity and health justice is becoming more and more prominent and visible. And these are powerful terms, and it raises the question about health and health inequalities outside of just disease control and individual healthcare consumption. So what is happening is that when we use the word health equity and health justice, people are like, what is this about? And we open up a conversation talking about what are the causes of ill health, what are the experiences, what are the consequences, and how can we start to address those factors? So this is impacting budgetary policies, which is that, many countries are both, every country, no matter, even if it's the United States, which is spending $3 trillion a year on healthcare, is not necessarily producing health outcomes as the outcome. And so, what we want to do is sort of change the conversation to, it's not how much you're spending on healthcare, but how much you're spending in order to improve health and good health, and where does that money go? So that would be one sort of important shift that we're trying to see. And in the UK, for example, we have sort of, organizations that are saying, every year we're increasing the spending on NHS, which is really important and needed, and it's actually starving of funds. But at the same time, our metric of outcomes should be health, not spending on healthcare. That sort of determines what we're going to do. But this is really, I think, particularly important for older people, is that we want to be able to prevent sort of acute health episodes and needs, but that means that we address the causes much early on, and this is outside of the healthcare system. So that's also something that I hope is getting greater attention as well. But I think that the answer here around, for me, health equity and health justice, and I've given you some examples of where my origins come from, there is a profound role for social and collective action when it comes to health equity. It is not just about what does the government give me or us. It's also about what do we do for ourselves together, for each other, but also how do we advocate for better institutions and institutions doing better and putting equity more at the center of what we're doing. So I think it's both collective action as well as sort of trying to get institutions to shift from the way that they're thinking about certain things.
Mm-hmm. I know there's a couple of things that I want to pick up on that you've just mentioned, which is that prevention component, which I think really it does tie into health equity in that, if you're making prevention accessible to the population, you really are kind of improving that ability to age in good health. But also, there's it really does, help to kind of make health available to all, or, give everyone that access to the right to health. But I think these kind of, a lot of people are asking questions about, money and economics and things like that, and where does it fit into government? And one of the challenges, I think, is that governments often have short-term mandates. And so I'm wondering if you have any thoughts on getting around that, because oftentimes health equity and things like that are very long-term things that, you'll see the dividends in the long term if you address these things, but that often doesn't respond to what, a policymaker wants to do in the moment, in order to get reelected and things like that.
So I'm going to answer in two parts. One is that when we talk about prevention, I want to try to ensure that when I talk about prevention, I am not disease focused. Mm-hmm. A lot of people, when they talk about prevention, is okay, so this is the major diseases that older people get in this population, so how can we prevent those diseases? I would rather think about how people are living their lives, and are they living the lives that they want to live? If people are able to live the lives that they want to live, I can assure you they're going to be happier, they're going to be physically healthier, they're also going to be able to help themselves, etc. So it's not a one specific disease that I would focus on, but I would also focus on the abilities of people to be healthy and living good lives. That's my conception of prevention over the long term. But also if and when they need various kinds of healthcare, that they should. So I just wanted to make this point that prevention is not about preventing illness. It's about making people stronger and able to live good lives that they want to live, and they will find the reasons that are being constraining and how do we address them. Mm-hmm. The second thing is that I can't, you all know, because some of you have gotten up very early in the morning for this, is that older people are a powerful group. They are an incredibly powerful advocacy group, both in terms of influencing their children who might be in political office or running hospitals or are doctors, or they themselves might be senior people in different kinds of institutions or ex-senior people. But they have the ability to shape public discussion beyond the short-term political cycle. And so it's a question of organization and collective action. So if there is a politician that's only thinking about the next cycle, that doesn't mean that older people have to take that as a given, right? They've been through this before. They know how this works. They know what the political cycles are about. And so they also know which levers to push in order to move things. So I think that it's a vastly utilized and mobilized group of people in terms of shaping the agenda for the next century, but also for the next few decades.
Mm-hmm. Yeah, I mean, that's a very powerful point. And you're, I think the cafe and everything that we do at IFA is certainly evidence of that. David, did you have one final comment?
Yeah, well, I wanted to maybe describe this situation and get a reaction to it. It seems that the pandemic in 2019, 2020 shocked people into thinking a little bit more about the conditions in which older adults were living, but it also shocked society into a dialogue about whether we need to be concerned about the pandemic, because it seemed that it was mostly affecting older people. So it didn't really affect society at large. It was just, and I put that in quotes, it just affected older people. But it also shone a light on the fact that many of the long-term care facilities were, not to be too dramatic about it, but they were like death traps, the way they were structured. And they were based on a philosophy of long-term care that was at least 35 years old. And so the political philosophy that led to the development of these older buildings that became death traps was out of date, but the longevity, the structures, the infrastructure of long-term care, of course, by definition, has a longer life expectancy. So it seemed that the whole system was discombobulated. You had people alarmed at the attitude that society seemed to be expressing about older people trapped in these buildings. You had that dialogue happening, but you had no capacity to bring the dialogue and the sort of political reality together. And when the government came in and said, well, we do need to put more money into building new buildings, the timeline on that was like about 7 or 8 years, which means that almost all the residents of long-term care would be deceased before there'd be any building changes. So it just seemed to me that the whole system was too cumbersome to react intelligently to the situation. I wonder what your comment on that might be.
I think you've stated the problem very clearly. What I would add to that, so it's not a direction to that, is that I haven't talked about the pandemic because I don't want to ruin many people's mornings. I don't want to make it into a horrible sort of morning. The pandemic was, I think, you're absolutely right by raising. So we're talking about 40 million people affected. So The Economist, I think, certainly currently says that about 40 to 50 million people have died either directly or indirectly from the pandemic around the world. But a significant part, most of the actual direct deaths and probably the sort of indirect deaths are older people. I cannot believe that we are not screaming more about this, because where is the discussion about the older people in the pandemic treaty that's being negotiated? Where is the discussion of older people in the future health systems that we're building? And where is the discussion about long-term care of older people? So, so much we've focused on access to vaccines as being the big issue, but it's actually the people that died are older people, and they died because of the way that we treat older people in our societies and the way that they are taken into or neglected or erased in the modeling and in the planning and in this idea of like, okay, we're going to imagine a standard household with 2 people and 2 children, and they, what do we do in order to help them survive this pandemic, while completely sort of saying, okay, we'll think about older people later on after we get this sort of general picture sorted, despite the numbers telling you that the older people are the ones that are dying and affected. That to me is injustice and neglect that we need to think about. So, what is also really a good opportunity here is that older people can not only advocate for older people in the future risks and pandemics and in society, but the empathy that the next time it might be middle-aged people that are going to be more vulnerable. So how would a policy pivot in order to focus on these particular kind of vulnerable groups as well? So, the issue around long-term care and, who has access to it, the quality of different kinds of conditions to it, et cetera, I think, at least in rich countries, is a question around privatization and what sort of regulation and what we think long-term care is about and should be about, is really sort of a central part of this. So I want to thank you for raising it, because I wasn't going to raise